Very good morning to all of you. Thank you, Dr. Amit, for giving me this opportunity to talk about cataract surgery in vitrectomized eyes. No financial interest. The common VR pathologies coexisting with cataract include vitrectomized eyes, buckled eyes, diabetic retinopathy, high myopic eyes, and retinal detachment. We could do this either as a combined procedure along with anterior segment surgery plus posterior segment surgery, or we might have to do cataract extraction in already vitrectomized eye or a buckled eye. Are these eyes different from the routine eyes? So the aim of this course is to make the attendees familiar with current strategies in the management of eyes with cataract and coexisting VR pathologies. There are certain risk factors for the development of cataract. The commonest complication of pars plana vitrectomy is cataract, and the commonest cause for this is intraoperative lens touch by instruments during pars plana vitrectomy. The second common cause is intraocular tamponade, whether bead gas or silicone oil, which produces cataract. Other factors are older age, diabetic retinopathy. There is usually a reversible feathering of the posterior lens capsule, which is seen after pars plana vitrectomy, but however, this is a reversible process. Influence of blood or inflammation leading to free radical release in the posterior segment is again a causative factor for cataract. There are certain anatomical differences which are responsible for difficulties that are encountered in SICS and non-vitrectomized eyes. From non-vitrectomized eyes, these are lack of vitreous gel support in a vitrectomized eye, presence of conjunctival scarring, compromised corneal endothelium, poor pupillary dilatation, zonular weakness or dehiscence, an occult pre-existing PCR, denser cataracts, low scleral rigidity, CME and worsening of diabetic retinopathy, and increased lens iris diaphragm retropulsion. Now, this conjunctival scarring in a vitrectomized eye, which makes the formation of scleral tunnel difficult, and the other slide is that of hyperoleon, wherein there is silicone oil present in the anterior chamber. So you need to first remove this before you go for cataract surgery. Plus, this is again responsible for reduced endothelial cell count and therefore poor prognostic factor. Preoperative assessment. Regarding pre-op assessment, patient counseling is very important because you have to explain to the patient about the poor visual potential following cataract surgery, so that patient does not have much expectation. Again, history is to be taken regarding to VR pathology and the extent of vitrectomy, which is very important. The extent as well as the number of vitrectomy procedures that have been undertaken. A lengthy procedure involving vitreous-based excision, there are more chances of zonular dehiscence and occult posterior capsule rupture. However, if simple core vitrectomy has been done as for macular hole or removal of epiretinal membrane, it would behave almost same as a non-vitrectomized eye. Needless to say, a good control of diabetic retinopathy is a must because it usually worsens after cataract surgery, and there is a higher incidence of CME in these patients. Coming to pre-op eye examination, look for conjunctival scarring, the endothelial cell count which should be measured. The anterior chamber is often deep in these cases. Thank you. Iridophacogenisis, which might lead to zonular responsible again for zonular weakness, pupillary status, nature of cataract, thorough retinal examination, and look for macular integrity in these eyes. IL-PAR calculation is very important in these eyes, and now there are two types of, we can categorize the eyes as eyes without silicone oil tamponade and with silicone oil tamponade. Eyes without silicone oil tamponade, you have to do IL-PAR calculation as you do for any standard cataract surgery. But eyes with silicone oil, IL-PAR calculation is little more challenging, especially the measurement of axial length, which is challenging in silicone oil filled eyes because it gives erroneous axial length measurement. The reason being sound travels slow in silicone oil as compared to vitreous. Second part is calculation of an appropriate IL power and how to choose an appropriate IL design in these eyes. The difficulties that we usually encounter in silicone oil filled eyes are, on B scan, the globe appears elongated and gives little information. On echogram, the retinal echospike is small and difficult to display because of sound attenuation. It is difficult to obtain axial length measurement, as I said, because sound travels slowly in silicone oil. In incomplete silicone oil filled eyes, you should do biometry in sitting position. If it is a case of immature cataract, then IOL master is the choice. However, in case of mature cataract or PPC, wherein axial length cannot be measured by IOL master, then we have to go for ultrasound. In cases of eyes that are filled with gas, ultrasound echoes are often blocked. Now, how to correct this apparent axial length to true axial length? There is a formula, but what you need to remember is whatever axial length you are measuring on biometry, just multiply it with a conversion factor of 0.71. This would then correct for the apparent increase in the axial length induced by silicone oil. And this value can then be fed along with K1 and K2 values to find out the exact IOL part. In certain eyes, however, it is impossible to obtain the axial length. In that case, the following options may be considered. We could measure the axial length before we are surgery and silicone oil injection. You could measure the axial length after you have removed the silicone oil doing cataract surgery in the second sitting. One could measure the axial length of the fellow eye, provided the patient is not one eye. CT could be used for the purpose. But the final option, however, is to consider the use of standard par IOL. Silicone oil alters the optics of the eye. As you can see here, in phakic eye, the silicone oil is acting like a minus lens. Now, as you can see here, this is a phakic eye, and here silicone oil is, this is silicone oil, so it is actually acting like a minus lens, and therefore the rays would diverge and come to a focus behind the retina. This therefore produces a hyperopic shift. On the contrary, in aphakic eyes, it is bulging here in the pupillary area, therefore acting as a plus lens, and therefore producing a myopic shift with oil. These are the refractive changes produced by silicone oil in phakic and aphakic eyes. So, more the curvature or part incorporated in posterior surface of the lens, greater would be the post-operative error. So, if you want to achieve emetropia when you are planning for, say, cataract extraction along with oil removal, so whatever IOL par you are calculating, you should add 3 to 8 diopters. Like if you are injecting in silicone oil, because silicone oil is going to produce a hyperopic shift. So if you want to achieve emetropia, if it is a biconvex lens which you are using, you need to add 8 diopter. And if you are using a plano-convex lens, you need to add 3 diopter. 8 diopter because it is a biconvex lens and silicone oil would be acting as a more minus lens. But if it is a plano-convex lens, the silicone oil would be less, it would acting as a less par minus lens. So therefore, the rays would come to a focus accordingly. Myopic shift is, however, expected after you remove the oil, which is greater with biconvex than with plano-convex lenses. Thus, when silicone oil is filling the vitreous cavity, the rule of thumb to arrive at the necessary IOL par calculation is as follows. Use convexo-plano IOL with the plane surface facing posteriorly to minimize the effect of silicone oil. We need to add 3 diopter to the calculated IOL par if you want to achieve emetropia. If you are using a biconvex lens, however, you need to add more, that is 6 diopter to the calculated power. But when silicone oil removal is done, then again 2 to 5 diopter of induced myopia is expected. The choice of it, coming to the choice of intraocular lens, hydrophobic or hydrophilic acrylic lenses, they give satisfactory outcome. A rigid Parma IOL is also well tolerated, but do avoid using silicone IOL. The reason being, silicone oil tends to interact with the posterior surface of IOL in patients with PCR. So thereby impairing the visual acuity of the patient, and also fundus visualization both intra as well as post-operatively becomes difficult. Now here this is silicone oil which is adhered to the posterior surface of silicone IOL. Oil removal has already been done in this eye. A 360-degree squarish design with large optic diameter gives greater viewing area for fundus examination. Small and ovoid optic lenses should be avoided. A plano-convex configuration of the implanted IOL with the plane surface facing posteriorly ensures minimal refractive surprises, and absence of holes is again helpful. The anticipated intraoperative problems are, because it is a vitrectomized eye, so obviously ocular hypotony, there is no need to massage. If you feel it is a very soft eye, you could use more of viscoelastis. The most important problem which the surgeon encounters is that red glow is often absent. Like if there is RD or vitreous hemorrhage, the red glow the visibility is very poor because of the absence of red glow. So surgery is therefore a little more difficult in these eyes. The anterior chamber is unusually deep. You could therefore keep your bottle height little low. Zonules are compromised, so there are chances of zonular dialysis. The pupil is often poorly dilated, capsular bag might be loose. There could be an occult PCR and therefore there could be drop nucleus or drop of cortical fragments. Posterior capsular plaque, especially in silicone oil filled eyes, and infusion deviation syndrome. As far as coming to the surgical technique, as I said, because of conjunctival scarring, scleral tunnel is therefore more difficult to make. It should always be made opposite to the area of zonular dialysis if present. Capsular exit is often challenging in these eyes because of poor red reflex owing to the coexisting posterior segment pathology, anterior capsular fibrosis. It is therefore better to stain the lens capsule because visibility is already low. It should be adequately large in size because these cataracts are often more dense. Hydrodissection should be slow and gentle, especially if it is, I'll tell you, especially after a vitrectomy, if the patient develops mature cataract immediately, I mean a week or so, then you should always think that there has been a touch of the lens with your intraocular instruments during VR surgery. So you should always keep in mind that there is a PCR definitely present. So in that case, it is better to avoid doing a hydrodissection. Only hydrodelineation would suffice. Or there is no need to do hydrodissection or even hydrodelineation at first if it is a mature cataract. Nucleus management. These vitrectomized cataracts are often dense. The nuclear rotation and also prolapse should be very gentle so as to avoid stress on the compromised zonules. The nucleus is more mobile and there is more deepening of the anterior chamber in these eyes. Now, what is this infusion deviation syndrome? We expect the anterior chamber to be deep, but sometimes there is paradoxical sudden shallowing of the anterior chamber and you tend to increase the bottle height. But however, this would further worsen the condition. It's better to inject viscoelastic. The cause for this infusion deviation syndrome is the fluid actually goes through the zonular defects from anterior side to posterior side, thereby pushing the iris lens diaphragm even forward. So therefore do not increase the bottle height in these cases. Cortical cleanup, you should be careful. It could be a little messy if there is silicone oil in the anterior chamber and keeps coming from the posterior side. You could do a posterior capsular polishing or remove the posterior capsular plaque. If not, then you can do a YAG laser later on. Pupils are often small in these cases, so you could use your own technique. It is, however, a very good technique is to hook up the nucleus with cystitome and then lift it with a dialer with the other hand. Now this is a dense posterior capsular plug in a vitrectomized eye. So you could do either polish it or dissect it with a needle, if not, or you can even perform a primary posterior capsular exis. Again, IL implantation also you should be very gentle. It should be very gently rotated, keeping in mind that there could be a zonular dialysis, and use CTR if there is even case of zonular dialysis. Post-op inflammation is more common in vitrectomized eyes than the routine eyes. Incidence of CME, worsening of diabetic retinopathy, is more common. Corneal edema is very common in these eyes because of the compromised corneal endothelium.
Dr. Usha.
Pseudophokic bullous keratopathy. PCO is the commonest complication of these eyes. Thank you.